This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
Hello, everybody, and welcome back. Welcome back to the SimKit podcast. I am excited to have a return guest. We've been having a couple of those lately. It's cool. It's exciting. I have a return guest today with me in Dr. Mike Burla. Mike and I chatted a while back, I guess in August, about blood pressure considerations in the post-ROSC patient and where we might want their MAP to live. We also talked a bit in that about temperature. Talked about TTM2 and we talked in that podcast a little bit in August 2023 about TTM2, and we're back today. We are back to discuss societal recommendations which seem to be changing with regard to temperature management in the post-ROSC patient, ROSC, return of spontaneous circulation patient. So Mike, thanks for coming back to chat with us today. Tell us a little bit about what you've been up to since we last talked and your role in these out-of-hospital cardiac arrest patients and your research.
Thanks again for having me. It's always a pleasure. To give a quick summary, Dr. Teresa May, one of the intensivists at Maine Medical Center, developed a program called the Post-Cardiac Arrest Learning Community, or PCALC. And the purpose of the project was to come up with strategies to improve overall care of these post-ROSC patients, specifically in the rural communities in the rural setting, as it can be a little bit more challenging to care for these patients in that setting. As you know, there are several critical access hospitals in and throughout Maine that receive these patients and need to transfer them to definitive care. So we meet monthly to discuss case review and different ways we can improve on the transition of care from emergency department to the ICU, emergency department, to transfer to the ICU, things of that nature.
That's fantastic. I mean, these are high intensity, high resource patients. In our, we work a lot in a community hospital that's quite close to that ivory tower, caring for them in a rural environment with a 2, 3, however many hour transport time, and the amount of staff and care that they need in that time frame. It's going to be a lot. So working with these people and these community providers to make sure that they're following best practices, that they're well supported, and they're getting their patients to a final disposition, covering all the bases of what needs to be done. Sounds like a fantastic project. So thank you for the work you do there.
Oh, for sure. It's been, again, Dr. May, is hosting these meetings, and it's been an amazing body of work, and something that, I'm passionate about. For myself specifically, I've been looking at our process of actually transferring these patients out. And to keep it short, we've looked retrospectively over the last couple of years to see what has been going on during these transfers. Are there physician orders or vital sign parameters in place? Is there variation between different agencies? And for myself specifically, I've been looking at our process of transferring these patients out. We looked retrospectively to see if there was any inconsistencies between physician orders and vital sign parameters or difference between agencies. And long story short, we found very little physician orders being placed and essentially no vital sign parameters during the transport of these patients. And so I think in an ideal situation, we'd have some protocolization, to try and optimize the care and get it as close as possible to an ICU level care prior to, arriving to the ICU. And I would say similar to our STEMI transfers, right? Those are very protocolized. You get the Plavix, the heparin drip, the nurse is ready to go. Everything's set up, to optimize the care. And I would say, we're trying to move towards that direction with these post-ROSC patients. And I've been working with our colleague and our local EMS director, Dr. Mia and Crusay, on that. So,
yeah, that's fantastic. And having those recommendations, and I'm always a guideline person as opposed to a policy person, because every case, every patient's different. But just giving directionality of what we should do, what are best practices in terms of blood pressure, temperature, glucose, all the things that we need to consider. And I'd argue that these patients are more unstable and more prone to bad outcome from the care provided once they get a pulse back than the STEMI patient that is only in your department for a short period of time before getting their PCI.
No, I would agree completely.
Perfect. So Dr. Burla, we are here largely to talk about the AHA recommendations that actually came out around the time of our initial conversation in August. And these are titled Temperature Management for Comatose Adult Survivors of Cardiac Arrest, a science advisory from the American Heart Association. In this publication, they put a lot of credence to TTM2 study and state, quote, for unresponsive post-cardiac arrest patients with characteristics similar to those of individuals included in the TTM2 trial, out-of-hospital cardiac arrest, of cardiac or unknown cause, excluding those with unwitnessed asystole, controlling patient's temperature to less than 37.5 Celsius is a reasonable and evidence-based approach. Mike, what are your thoughts on these recommendations?
I think it's reasonable for sure. I think they're well thought out recommendations, and as we mentioned before, the patient population in the TTM2 study was a fairly healthy population, predominantly without significant comorbidities. It was a majority male, younger age, around 63 to 64, with low levels of diabetes, hypertension, and patients that experienced a witnessed arrest with a shockable rhythm. And, when you don't include unwitnessed arrest or initial rhythm of asystole or what they deemed as, quote, limitations in care, I think when you focus specifically on this patient population that is known to have better outcomes, looking at the temperature range that they evaluated, I think the statement makes a lot of sense. I think that it's recognition that TTM2 was a very well done study and that those temperature ranges do appear to be applicable for that patient population. So, if we had a patient with a witnessed arrest, and even more specifically with a shockable rhythm such as VFib or VTAC, maintaining a temperature between 32 and 37.5 degrees Celsius does seem reasonable. I would say that the brief update does note that there is still a recommendation that if the patient is not making purposeful movements, i.e. not pulling for the tube or not following commands, things of that nature, it is still recommended that patients have, quote, a deliberate strategy for temperature control. So, I think what we could take away from that statement is while this specific patient population might not need as aggressive as cooling as we initially thought, you simply can't just forget about the temperature. It's still a vital sign where there needs to be some parameters in place, at least based on the literature we have today.
Yeah, that makes sense. And thank you for bringing up some parts that were in our initial conversation. And for folks listening, we will have a link in the show notes to our initial chat on the topic. But for TTM2, Mike, you had some legitimate reservations. And of course, that being said, that did not affect these AHA updated recommendations we're discussing now. So thanks for sort of bringing that to light. I think whenever we have these societal recs, we need to know where the evidence is pointing, where the recommendation is coming from. And it is essentially wholly based on TTM2. A lot of the prior work showed a pretty prominent or pretty definitive benefit to cooling, and cooling to a relatively cold degree, right? We initially were kind of at 32, 33, and then we've seen some studies, okay, maybe it's 36, and now we're basically between 32 and 37 degrees. And you brought up one element that I think is worth highlighting again in thinking about these recommendations and thinking about TTM2. So the first of which is the applicability. TTM2 is definitely the largest and a very well done study on targeted temperature control in someone who is post-cardiac arrest who has ROSC. But recognizably, this was a Scandinavian study. And as you mentioned, that patient population, their protoplasm might be a little bit healthier than the average American who comes in post-ROSC. And so knowing that and knowing the application of the data to the patient in front of you is super important. So knowing that it's more witness arrests, more VFib, VTAC, and in Scandinavians who had fewer comorbidities. That said, it probably and doesn't seem to be affecting the recommendations for general care in America and other developed countries. The other point that you brought up in our initial chat, I was hoping you could sort of tell us your thoughts on that now, is about basically our progression in care of the post-ROSC patient. We had the HACA trial, we had the Bernard trial, TTM1, TTM2, and the pendulum is a swinging, my friend, right? We are going from keeping them very cold to maybe not so cold to now just basically preventing a fever.
Oh, yes.
And you made the analogy of sort of Rivers and early goal-directed therapy and showing how that had such a profound impact. And over time, all of the elements of early goal-directed therapy were kind of chipping them away, and maybe recognizing that it's just a focus on the patient and really being cognizant of their progression in the emergency department. Tell me your sort of standpoint on that and how that might apply to the post-ROSC patient.
Yeah, I think that kind of the progression of what we've seen in the literature does reflect when we think about sepsis and how we approach sepsis patients, and the pendulum swinging back and forth between needing specific things that early goal-directed therapy had, that to now not needing those things.
Yeah, I'm not checking wedge pressures anymore,
Exactly right. And, perhaps our approach to those patients are different. And I do think the same can be said with this patient population. When we look at other vital sign parameters in post-ROSC care, there are varying degrees of literature to suggest the optimization of care. For instance, as we touched on with our first talk, aggressive blood pressure management, specifically within the first couple hours of achieving ROSC, there's been evidence of, improved outcomes. And the AHA recommendations have guidelines based on that. But when we look at, strict glucose targets, the studies that have been out there haven't necessarily shown improved outcomes when you have a specific target to avoid hyperglycemia, for instance. So whether you're targeting a range of 140 to 160 or 140 to 180, it didn't really make a difference. However, the benefit of preventing hypoglycemia has been shown. And so as long as you're closely monitoring the glucose so it doesn't dip to a hypoglycemic state, you're likely providing some benefit. And again, I think as more and more studies come out about targeted temperature management and hypothermia, I think from a temperature perspective, there similar statements can be made. And again, specifically with this patient population of witnessed arrest, predominantly VFib and VTAC or shockable rhythm, whether you target 33 or 36 or even 37.5 degrees Celsius, it probably doesn't make a difference. But as long as you're closely monitoring the temperature to prevent degrees of hyperthermia or pyrexia, there should be some benefit.
That makes sense to me. And I do see that as being a potential downside almost of this leniency in temperature control, in that the time you spend in the room observing the patient and seeing their hemodynamics, their purposeful movements, etc., that matters, right? And if you are not as attuned to it back, years ago when we were trying to bring them down in temperature and we're going in and out of the room to see if we're reaching our target of cooling, that might be the benefit, right? Our time in the room, our hands-on patient, our communication with the nurse. And so now that we're kind of in more of a let it ride, don't let them get a fever algorithm or approach or protocol, there might be less time spent or less attention to the patient in that regard.
Yeah, I completely agree. I mean, I think you and I can both speak on this, in a community setting. When you have one of these patients, it's very easy for people to, get lax about the situation. Okay, we got ROSC. Okay, the first blood pressure's, 140 over 80 or something like that. We're going to get sedation. We're going to get this. We're going to get that. And then you might, if you're not necessarily glued to the bedside to make sure X, Y, and Z happen, which, like you said, when we were really worried about getting to specific targets, you were a little bit closer to the bedside. If you leave, well, maybe now the blood pressure dips and no one's really paying attention, or maybe the temperature rises and you don't have a bladder probe getting, continuous temperatures or things of that nature. And then now the patient, you check back and they're a little hypotensive, and maybe they're febrile, that's lost time. deviations in vital sign parameters you just can't get back.
Yep. Yeah, that makes a lot of sense to me, and it is totally fair. So I think it's going to be a very conscious effort for providers who are now not as stringent about temperature control to make sure that they're maintaining that touch point, because we all know what happens in a department, whether you're single coverage or multi. You have a post-ROSC patient, they need a tube confirmation, they need a central line, they need pressor starts, they need sedation starts. You put all this upfront work in, you come out of the room to the 4 or 5, level 3s, 2s, and whatever,
Right.
and then you have to go continue to provide care for the rest of your apartment. And if you don't have specific points that you're targeting and touch points that you're mandated basically to do in these patients, they may fall by the wayside awaiting transport.
Exactly.
Yeah. I wanted to ask you a little bit more in something I found interesting. So an interesting part of the current recommendations is to maintain a targeted temperature range of 32°C to 37.5, and specifically highlighting that lower limit of 32. In what we've seen in our data in TTM2, there probably is not a major benefit in hypothermia. So I suppose that this is based on the data that there's no difference in the outcome between really cool and just normal thermic. So if it's not worse to be really cooled, then I suppose it's okay. It's similar. Can you kind of give me your takeaway on that range that they created in the new recommendations?
So I think that part of it is just the lack of data on the out-of-hospital cardiac arrest patient in general, and specifically unwitnessed arrest with asystole or PEA. I know they weren't initially included in the recommendation of the temperature control, but if you look, we know they have a worse prognosis and it's a less studied population. There may still be some benefit to having, a cooler temperature in certain patient populations, but it's just there hasn't been enough studies done to suggest that, which the AHA brief update does mention. It does state that, there's, quote, insufficient evidence to recommend a specific temperature for different subgroups of patients with cardiac arrest. And I think that's directly referring to those PEA, asystole, unwitnessed arrests. And so, when we think about out-of-hospital cardiac arrest as a whole, and not necessarily excluding or only including witnessed VFib, VTAC, shockable rhythm arrests, I think at that point, you really do need to lean on your local institution's protocols or recommendations. We still have cooling pathway through main health, and depending on the patient and the potential need for more neuroprotectivity, we still have goals between 33 and 36 degrees. Now that may change at some point, but if you speak to our intensivists, that's still something that's in play. There just hasn't been enough research done to really look at this. I mean, there are still studies being conducted, that do look at this heterogeneous population. I mean, IceCap is one, for instance, the influence of cooling duration on efficacy in cardiac arrest patients. Now they're looking mostly at identifying an optimal duration of cooling, but they're including both witnessed and unwitnessed arrests who have, experienced out-of-hospital cardiac arrest. And I think that the more literature that is out there that includes this patient population, the better understanding we'd have of what an ideal temperature range is. Because for now, it's 32 to 37.5. So.
Yeah, and that's quite the range. And thank you for sort of bringing that to light a little bit, because it is an interesting area of lack of data. And I don't fault TTM2 authors for excluding unwitnessed or asystolic arrests. You don't want to have a dilutional effect in patients that are being kept alive by epinephrine or have a very poor prognosis. You want to be able to actually derive data of what can be beneficial in the lives and brains that can be saved. So I see why they targeted witnessed or VTAC, VFib arrests. But that doesn't mean that your patients aren't going to come in with the latter, right? It'll be great to have that Scandinavian gentleman straight off the cruise ship who comes in and sees goes down in front of people, they shock them out of it. That's great. Perfect applicability of TTM2. But we're still going to get Mima from the nursing home who was found, with unknown downtime with asystole, who got pumped full of epi and is now alive. And we have to figure out how to manage her properly as well. And that's an interesting wrinkle. It's great to hear that there's actually nuance to the care being provided through Maine Health. If you can speak a little bit more to when we're finding that lower target range to maybe be beneficial, or who are the ideal patients for this neuroprotectivity of hypothermia?
It is more at the discretion of the intensivist, but generally speaking, it's patients who have the potential for more risk of catastrophic neurologic outcomes. So, longer downtime, other factors that could relate to poor prognosis, like comorbidities and, a PEA arrest as opposed to shockable rhythm. Those sort of things fall into place. We actually do have an algorithm that you would, at least initially follow in the ED or look at as a guideline. And then when you speak to the intensivist, they can give you a little bit better idea on which temperature to really target. Generally speaking, if somebody's like hemodynamically unstable, that's another thing to consider. If someone's on multiple pressors and you're still having a hard time achieving an adequate map, that's another patient where, different targets and temperature need to be in consideration, where you wouldn't necessarily want to cool them too much, just because it has the potential to change their hemodynamics if they're already still somewhat unstable. So that's another thing to consider that's also in the algorithm. But at the end of the day, it does come down to, vital signs or, blood pressure aside, comes down to where they think the patient is best served at from a neuroprotectivity standpoint. And at the end of the day, I mean, we were just trying to do what's best for the patient. So.
That makes sense. And if I could pin you down maybe a little bit more on that, Mike, how are you currently handling the unwitnessed asystolic patient who comes into your ER post-ROSC?
So, I'm still, I would say, being at least from a management standpoint, initially aggressive as I can be, from making sure their blood pressure, making sure we can get a map above 80, making sure we're oxygenating adequately, and then, making sure from an induction standpoint to cooling, making sure that we're getting them cooled as soon as possible. Now, am I automatically targeting 33 degrees? I think that in the process of cooling, I'm on the phone with the intensivist pretty quickly to get some guidance, but in the absence of guidance, I'm still at least certainly trying to prevent hyperthermia, pyrexia, undesirable temperatures. But, at the same time, if I'm being aggressive treating the patient and trying to make sure that we decrease the time to their induction phase of cooling. And in the absence of instructions, I'm still cooling to 33 degrees.
Interesting. Okay. That's helpful to hear, and not to make light of the other things. So I think that's worth reiterating. All of the other parts of care, and some of which we talked about in our prior podcasts, are still very, very important. So someone comes in post-ROSC, you guys, we at Maine Health have a relatively, I'd say maybe aggressive, I don't know if you would agree, in terms of our MAP target being somewhat high, pushing toward 80 for a MAP, making sure that they are not becoming hypo or hyperglycemic, to make sure that they're not at risk for hyperoxia or hypoxia. Those things come into play in all of these patients. And then because TTM2 doesn't really specifically cover temperature in these patients, if you think that there is a benefit possibly to some neuroprotection related to mild hypothermia, it sounds like you're driving those patients a little bit lower.
Yeah, I think, I wouldn't delay transport or transfer to the ICU to achieve these goals. So if I got to 36 or, even 35 and it was time to transfer the patient or get them up there, I would say that's okay. But in the absence of knowing when the patient's being transferred or knowing when I'm able to get the patient out of the department, I am going to be, or again, direction from the intensivist via phone. I'm going to be as conservative, in my opinion, as I can be from a protection standpoint. And you're right. I think Maine Health does have some aggressive parameters, but the brief update and AHA does recognize that hospitals should come up with their own protocols for these patients that might not all be the exact same, because when you look at the guidelines, there are varying degrees of values for different vital sign parameters, which does include, MAP back in the 2020 guideline.
Yep. Okay. Yeah, that's helpful to kind of go over as we get closer to a close, just to summarize things, and feel free to interject and correct as we go. But looking at these AHA recommendations, basically coming off of TTM2, we're seeing that the temperature management pendulum, as we mentioned, it has swung relatively rapidly from quite cool to kind of cool to now a range of 32 to 37.5. We know from the data that we're quite well supported in not driving them particularly low, but most importantly, avoiding pyrexia or fever in patients that have a generally healthy underlying, medical history, who have good protoplasm. If they're Scandinavian, even better, and that have had a witnessed arrest and VFib or VTAC shockable rhythm, they come back. That is right down the pike of what TTM2 looked at, and we are well supported in that range of 32 to 37.5, not seeing significant benefit really in driving those temperatures lower. But as we do that, and as we think about other patients that will come across our department, particularly the asystole patients or the unwitnessed arrest patients, the data is not as well founded. We don't have as much support there. And within that, relatively large range of 32 to 37.5, there might be play, and there might be certain patients that benefit from a lower level or a greater degree of neuroprotection. All of this should be done in consultation with our intensivists, getting them on the horn early, obviously, to delay, the length of time in the department is very important, trying to minimize that and get to our targets, get our patients stabilized for transport as early as possible. And in those conversations, seeing what the intensivist who will be caring for the patient long term thinks about their ideal range within that 32 to 37.5.
I think that sums it up greatly. I think the main point towards the end, lean on your local institutions, policies and protocols, and what the ICU and the intensivists at your institution think from a vital sign parameter standpoint. And again, that's well illustrated in the brief update, specifically because we don't have great data on the out-of-hospital cardiac arrest patient as a whole when we include unwitnessed PEA, asystole arrests, and these patients are still coming to our doorstep, and we're still treating them. So, I think that's a good take-home point that we can't forget when it comes to this update.
Perfect. Excellent. So a collective summary about our conversation and our points of care in the post-ROSC patient. We are focusing on temperature here. That is the point of our podcast, but we would be remiss not to mention the other elements that are very important. So making sure that you are keeping their oxygen in a stable range, that they're not hypoxic, and we really don't want them to be hyperoxic either. We're not driving 100% FiO2 and a pulse oximetry of 100 either. We want to be conscious of that, conscious of glucose and MAP, and working on with your intensivist on what the ideal target MAP is going to be important as well. When we come to temperature, that is our AHA recommendation that we are reviewing here. We see our temperature range of 32 to 37.5, and there might be nuances within that, knowing the ideal patient for TTM2, again, that witnessed arrest, shockable rhythm, generally healthy, that fits that well. There are other patients that we have to care for who are not going to fit that bill, and we're still going to exist within that 32 to 37.5, but a little bit more nuance, and certainly something worth a conversation with your intensivist as you get ready for transfer. And globally, probably the most important take home here is, as we kind of made the analogy to early goal directed therapy, if we are becoming more lax or less stringent in our temperature control, we cannot forget that that does not mean we set it and forget it and wait for the ambulance to arrive, continue to care for the other patients. The touch points we have with our post-ROSC patient are incredibly important for recognition of nuances that you might not see in a chart review or in a vital sign trend. Getting in the room, laying hands on the patient, working with your nurse to make sure you're addressing all the things that they are seeing or coming up with are vitally important for the long-term survival and the morbidity for these very sick patients.
Exactly. And that's what, the AHA means by deliberate strategy, having a strategy for these patients and, sticking to it.
Perfect. Well, Dr. Burla, thank you again for coming on and chatting with us about these recommendations, the work that you're doing with our post-ROSC patients. I appreciate everything you do and taking the time to chat with us today.
Thanks for having me.
As always, SimKit is here to help you gain confidence and competence in rare procedures. Want to get more facile with Linton, Minnesota, Blakemore? We have tips, we have tricks, we have models that deliver right to your doorstep. Crike, lateral canthotomy, tube thora, same thing. Models that deliver to you an education that walks you through the procedure and holds your hand the whole way. And we're CME accredited. Check out the link at the bottom for more.